5, 4, 3, 2, 1. We are live now, sir.
Okay. Warm welcome to the another session of Pediatric Orthopedic Fellows Active Learning Session. This time we are very fortunate to have two eminent experts of Pediatric Orthopedic. We have first Professor Matthias X from Australia, and we have another expert from India, Benjamin Joseph. To introduce both the experts, I request Dr. Abhay Gahukamble. And I must, first of all, appreciate your efforts to invite Matthias on our behalf to share his knowledge and experience with our fellows. So, Abhay, can you introduce Professor?
Yeah, thank you, Dhirenba. It's truly a pleasure and honor to introduce Dr. Matthias Axt. Dr. Axt is a senior staff specialist in the Children's Hospital at Westmead in Sydney, Australia. He's been the head of the department of the Orthopaedic department for many years and only recently has handed over and is also a senior clinical lecturer with the University of Sydney. So he did his initial training in Heidelberg in Germany, and then he's moved to Australia almost in 2004 in the Children's Hospital. And he leads the cerebral palsy service and the multidisciplinary neuromuscular service. He's got extensive experience in neuromuscular disorders of almost 30 years, and he's been vital in starting the GATE laboratory, the GATE analysis service of New South Wales in the Children's Hospital. And in the short time that I've been here, I've been exposed to spinal muscular atrophy, and it was essentially the driver which I thought that it would be good for him to share his knowledge with the fellows, because it's an area where very often we restrict ourselves to just cerebral palsy, and it's good to get a wider spread. So it's truly an honor to introduce, and I'm glad that he's taken the time to join us, even though it's 10 p.m. on a Friday night in Sydney. Benjamin Joseph says there's no need for me to introduce him to our Indian audience. All of us who do pediatric orthopedics, know that he is one of the pioneers. And from the time you're a postgraduate to a fellow to a consultant, you look up to some people and all, and he's definitely one of them. So he's world renowned for his work in Perthes, but he has published and has contributed to pediatric orthopedics, and I think every field that is relevant in our scenario in the Indian subcontinent. And he's, as has been mentioned before, he's written many books, which should be essential reading for any fellow or pediatric orthopod in India. So it's an honor to listen to you again, and thank you for being here. So I think there's lots that we can accomplish. I leave the talking to the experts now.
Yeah. So now I request Professor X to share his presentation, and the presentation will be for 30 to 40 minutes. And after that, we will have a question and answers session. And at that point, we will try to ask very relevant question for Indian perspective, because Australia and India have a very different healthcare system. So each has their own advantage and disadvantage. So that we will discuss after your presentation. Over to you, Professor.
Thank you very much, Dhiren. It's an honor to speak before so many people. Can you see my screen?
Not yet.
Let me just see what happens. Just see what happens. Okay. Can you see my screen now?
No, it's just my video which is seen over there, not the presentation.
Okay. Let me just see whether we can get this to work today. Enter screen. Any better?
Yes, now. Yeah.
You can see this now?
Yeah, we can see the slides. We just need to go to the full screen. Yes, now it's full screen also. Perfect.
Excellent.
Yeah. Thank you.
Again, thank you for your invitation, and thankfully that screen did work in the end. I would like to tell you a little bit about hip displacement in cerebral palsy, but also low-tone neuromuscular disorders, and the principles of how this comes about, and some of the principles of the management, and also a couple of examples how we try to push the boundaries a little bit. So, about can you see the next slide? I hope you can.
Yeah.
Good, excellent. So in cerebral palsy, we have about 35% of all cases of hip displacement. And Kerr Graham was the one who actually linked the rate of hip displacement to the GMFCS. So the higher the GMFCS, the more likely we have hip displacement, and in GMF4 and 5, we have 70% and 90% respectively. The displacement in cerebral palsy is different to DDH. It is not only superior, it's also more posterior, because the posterior rim is less developed in children with cerebral palsy, and it also has to do not only with the development of coxa valga, but also with the persistence of what we call anteversion of the femoral neck. We should actually really say antetorsion, because actually it is a torsion of the femur and not just a version of the femoral neck. I had a discussion with David Little not so long ago, and I agree with him that this should be the right term. Anyway, most of us understand anteversion. I think I use this term in future. So how does it come to hip dysplasia in cerebral palsy, but also other neuromuscular conditions? And we have for many years talked about spastic hip disease at length. But we found that some of the entities are very similar to what happens in cerebral palsy. And we do know that spastic muscles are not necessarily strong. They're spastic, but they're also weak. So the first reason for hip dysplasia in cerebral palsy is muscle weakness. The second is muscle imbalance. We know that spastic muscles are typically also weak, but that the biarticular muscles overpower in spasticity monarticular muscles, and thus these are the hip adductors and the psoas. The third and very important factor is lack of gravity, and this is probably why we have such a huge range of hip displacement in cerebral palsy in GMS4 and 5. So lack of gravity is, regardless what entity it is, it plays a big role. And we know that, for instance, the femoral anteversion only remodels from 30 to 35 degrees when we're born as a baby. It actually increases a little bit during the first year. And then once the baby starts weight bearing, then the anteversion develops from about 30 to 35 degrees back to 10 degrees as an adult. Muscle tone does play a role, and that includes spasticity as such. And therefore, we also have developed many tools to treat spasticity as such. And on the right-hand side, you see, can you actually see the mouse on my screen? I hope you can. This is a chart with cerebral palsy, GMS5, 3.5 years, and you see that the left hip is subluxed. You see several features of the hip dysplasia in this chart. This is signs of coxa valga. I say signs of coxa valga because it's always a mix between anteversion and the true valgus deformity of the femoral neck. It is the wide teardrop, as you see here, and it's the steep acetabulum on both sides. On the left side, even as a 3.5-year-old, this chart even already has some irregularity and asphericity of the femoral head. So these are examples on the next slide I want to show you that are basically uniform to neuromuscular conditions, whether they are low tone or high tone. On the left slide shows a child with a mixed tone quadriplegia after brain injury. The child was 5 years old, Jim was 5. And you see again, you see the osteopenia, you see the gracility of the bones, you see the poor development of the acetabulum, you see that the physes are horizontal. And if you compare this to the next on the right side, it has very similar features. That's a child with spinal muscular atrophy type 2, again, 5 years. I could basically mix them up. If I would turn them around, no one would probably know the difference. The only difference is here. If you look at the ischial ramus, you see that it's actually dragged out, and that's dragged out by the spasticity of the hamstrings, whilst you don't see this in children with SMA. How do we measure lateral migration or hip displacement, hip dysplasia in children? Typically by the ramus migration percentage, although we tend to mix up acetabular dysplasia as well as lateral migration. On the left-hand side, you see a hip that has both true lateral migration as well as acetabular dysplasia. I would rate the migration percentage as shown here of about 45%, with the corner of the acetabulum a little bit blunted, whereas on the other side, we have acetabular dysplasia. Again, we have probably an uncoverage of about 30 to 35%. And I feel that acetabular dysplasia is probably better measured or taken or regarded with the acetabular index, which shows the inclination of the acetabulum, or in the combination of both lateral migration as well as acetabular dysplasia, as on the right hand side, the so-called Wieberg center edge angle, which is measured by a perpendicular line on Hilgenreiner's line going through the center of the femoral head, and a line going again through the center of the head and through the corner of the acetabulum. You know, so there is a little bit of a mix up, I feel, because the ramus migration percentage is used for both, for acetabular dysplasia as well as for lateral migration. I feel there should be a better instrument to measure acetabular dysplasia only, which is quite difficult to do. And several attempts, including myself, tried to, and David Lill, by the way, I learned this yesterday, he and Justine tried to find a better measure to value hip dysplasia, acetabular dysplasia, and so far there hasn't been much of an instrument. The other thing we need to regard is how well the so-called sourcile, so the corner of the acetabulum, is formed, because that gives us also a hint, an idea how we treat that patient. So on the left-hand side, this is actually the same X-rays as before. You see that the corner, the so-called sourcile, is quite well developed. And Freeman Miller called this the type 1 acetabulum, whereas on the other side, you see that the sourcile is steep and blunted. Freeman Miller calls this the type 2 acetabulum. He has published this in a paper which I've quoted down here on the bottom of the slide. So now it comes to treatment of hip dysplasia, hip displacement in cerebral palsy. And we know that bracing in low muscle tone conditions has little evidence of success. However, if we have spasticity sorry, I have a bit of a dry mouth at the moment. Maybe I'm going to get a glass of water in a minute. Kergram has written this paper, or has done an RCT about the way to brace children after botulinum toxin injections. And he found that he actually, in his paper, regarded this as a complete failure, because most of the children, as depicted here, he had two groups. One group with a migration percentage of more than 10% to less than 40%, age 1 to 5 years, with a mean age of 3 years. One group of 64 had the treatment of botulinum toxin injections plus bracing with a swash brace, and the other group had nothing. He found that many children needed surgery in the treatment group. However, and that's actually, I talked to him about his own results. I felt that he bought time with these ways to treat the patients of at least 1 year. So why is it important to delay surgery, and in particular bony surgery, for some time? I will talk about this a little bit later. So I would call this RCT not really a failure. It gives the opportunity to buy some time as such. On the left side, I don't know whether everyone knows the swash brace. A swash brace is a so-called sitting, standing, walking hip orthosis, which can be used all the time. The patient can stand and walk in it. There's a picture depicted here, and the hip flexes and actually abducts at the time of flexion as well. So let me have one more word about bracing. Bracing in children with high spasticity is not a good idea as such, because we have increased muscle tone, and Freeman Miller in the late 1990s has done a computer model of spastic hip forces, so forces within the cavity of the hip joint, and found that the pressure and the forces within the hip joint in a child with spasticity is about 3-fold compared to a normal child. Whereas, and when you actually abduct the hips in such a child, you increase the pressure within the hip joints to 6-fold. Therefore, yeah, you may as well hurt that hip and the structures within the hip, and also you cause pain, and therefore hip abduction bracing should never be done in a spastic child without previous management, like either botulinum toxin injections or what I'm talking about now, release of the spastic muscles, that is predominantly the hip adductors, adductor longus and brevis, parts of brevis. In those children who are not able to walk, are also address the brevis, gracilis, and also the psoas. The psoas at the lesser trochanter, followed by bracing. And some of those children have a good success. This child, for instance, also a child with cerebral palsy, quite spastic, age 4 years, and a migration percentage of 70%. She's one of those who was very lucky and developed an almost normal hip, as you see on the middle picture. However, do we have success all the time? Probably not. Freeman Miller in 2005 published an article and found that after hip adductor releases plus obturator neurectomy, 49% of the patients had a good outcome. That means a migration percentage of less than 24%. However, he did not consider the GMFCS. Graham in 2012, he again compared patients who had hip adductor release and regarded the GMFCS. He found that for those children who most need hip adductor, or actually hip management, the GMS level 3, 4, and 5s, but in particular 4 and 5s, that the success rate was only 27% in GMS level 4 and 14% in GMS level 5. So the Kaplan-Meier curve here shows that the lowest curve is the GM05 curve, shows that we only have long-term success of 14% to maintain or keep the migration percentage below 50%. So long-term hip adductor management, hip adductor release is also not successful, unfortunately. So what should we do? Which age should we treat hip dysplasia with hip reconstruction, and what procedures should we actually undertake? This is an example I got sent quite a few years ago, coming from a peripheral hospital. This child at the age of 4 years had bilateral VDRO with this device. And to my knowledge, hip adductor release at the time was not done. So the pathology actually was not really addressed. And soon after, at the age of 6, so 2 years after the operation, not only had both bones re-valgized, both femora, but also the left hip is now dislocated. So that child needed another operation because of this. So when do we actually safely do bony reconstruction? An answer is given by Reinhard Brunner in Switzerland in 1996. He compared VDROs of different age groups between 4 and older than 12, and found that whilst the neck shaft angle, of course, was corrected immediately after surgery, in those children younger than 4 years old, the neck shaft angle remodeled 96% very quickly, and also even the derotation he introduced into the surgery remodeled to 42%. So he found that it is best to wait until the age of 8, but at least the age of 6 before we undertake bony reconstructive surgery. So meaning that what I do here is buying time. Children with subluxed hips and spastic and tight hip adductors have hip adductor releases first, are being braced. We observe those children very closely, of course, and once the hips further deteriorate, then the child undergoes hip reconstructive surgery. So what actually should we do when we do hip reconstructive surgery? As I said, best timing would be after the age of 6 years, at hips at risk of with a migration percentage of more than 30% and progressive dysplasia. And here I've actually quickly mentioned the hip surveillance. Our rehabilitation department does hip surveillance very, very closely. I have to say, I looked into this myself. There are so many rules that I don't obey these rules probably. I know that the rehabilitation department does that, and I'm very happy with this. And of course, I observe those hips as long as they are progressive very, very closely, and stop once they don't further progress. But personally, I leave the very strict rules of hip surveillance to our rehabilitation department. So the other features which we consider for hip reconstruction is signs of coxa valga, white teardrop. White teardrop is always a sign that there's not enough pressure on the center of the acetabulum. The acetabulum actually tries to follow the dislocating hip. And then also the type 2 acetabulum is very, very important for what we do for those children. All right, so there are many, well, I would almost say defenders of various operations or various derotation operations of those children. And I would like to show you one example. I have many examples, unfortunately, not, well, I personally like something else, but historically, predominantly VDROs were done in this hospital, and therefore I have quite a few examples of, I have to say, failure here. So this child was at the time 11 years old. She had a type 2 acetabulum on actually both sides, but also predominantly on the right side. And she got a VDO, and it doesn't look so bad. You know, if you here would measure the migration percentage, you would probably find that the migration percentage is only like 30 or 35%, given the tilted femoral head. But if you follow this patient up further, 4 years later, the acetabular dysplasia was quite obvious, and 6 years later, the hip was painful. So in that age, this patient was 17 years old, and the only thing that could be done was a triple osteotomy or a periacetabular osteotomy to salvage this hip. Would something else like a pelvic osteotomy been done at the time when she underwent the first set of operations, this would have probably not necessary. All right, so therefore, I propagate to combine a video with a pelvic osteotomy, like a Dega osteotomy, when the acetabulum is short, and when there is true lateral migration, when there's progressive lateral migration, when the acetabulum is steep, like on this picture. And I show another picture quickly. Again, lateral migration on both sides here with a steep acetabulum. And you can actually, although it looks like there's concentric acetabulum, after the Dega, it's still concentric. It's much better covering the femoral heads on both sides, and the sourcil is basically restored. So I'm aware that some people say that the acetabulum is no longer concentric. Well, I feel, first of all, it is, and secondly, there has been a Turkish study quite a few years ago measuring the volume of the acetabulum before and after Dega osteotomy, and they found that the volume of the acetabulum has increased after the surgery. Is there evidence that video on Dega really has benefits? There is, if you look through the literature, there is widespread, I would say, widespread disagreement, and this is why I found we look into at least the odds at hip stability if you combine both surgeries, video and Dega, with video only. And in our group of 46 hips with video Dega versus 28 hips with video only, and a mean follow-up of 4 years, basically, we found that the odds of hip stability at the final follow-up was 3.5 times higher in the video Dega group than in the video group alone. We also found that the migration percentage in the video Dega group remained on the safe side, below 30%, whereas, and that's actually kind of a surprise, with the video you manage to improve the migration percentage because you probably push the whole femoral head a little bit more into the acetabulum, but it doesn't last, and you go back into more dangerous terrain in the mid 30s at least. And also the acetabular index, of course, it can't improve after video only, but it rapidly improves with the video in the video Dega group. And the video Dega group actually had a worse acetabular index to start with before surgery. However, in the video group, we did see some improvement over time, so which indicates that there's some development happening at the pelvis, including around puberty, when the forces are correct and right, that then the ring apophysis, which is cartilaginous and doesn't appear on X-ray, this ring apophysis can then ossify, typically in girls at around the age of 12, and boys around the age of 13 to 14. So now I will focus on a few cases and also on salvage operations. We have here a patient, 21 years old, with a hip dislocated and a most severe kyphal lordosis. The hip is actually is very prominent and almost tries to penetrate the skin. This is the intra-op view or the just pre-op view. After prepping, I thought I'd take an X-ray. So it was extremely painful. And in that case, once the hip is not salvageable, then I would do what we call a castle procedure, where the neck and the head and the neck is being resected below the lesser trochanter. And that's actually how that femoral head looked like. And then there was no cartilage on the femoral head anymore. And of course, this hip is not salvageable. Just a little trick I've felt is important for the younger ones of us. When we do a VRO, we try to put, I use usually a 90-degree angle plate, and we try to put the angle plate as high as possible, because after quite relatively short period, so this is 3 months and 10 months post-op, yes, there was a little bit of a revalgus happening, but also what you see with growth, the tip of the plate comes closer and closer to the calcar, and at some stage may penetrate if you start too low. I also would like to mention, we have already talked about low-tone muscular disorders, and I would like to quickly mention the principle of management in children with spinal muscular atrophy. You probably know, even everyone. Maybe I say a little bit too much if I give some definition of SMA. It's related to progressive muscle weakness because of the disruption of the survival motor neuron 1 gene, and that leads to the degeneration of the anterior horn cells. So these children have progressive muscle weakness, and as we already heard earlier, progressive muscle weakness leads to hip dislocation, hip subluxation, dislocation, because the patient or the muscles or actually the bones don't know what to do. So they have to do something. They don't know what to do. There's no concentric muscle forces around the hip. So this is why they dislocate. So historically, hip reconstruction for those patients was not regarded, and there was also a high rate of redislocation observed and considered. Even very recently, someone said that a unilateral and bilateral hip instability should be surgical managed in patients only if they have significant pain. However, we have entered a new age, and that is the age of gene modulation therapy. In 2016, nusinersen was introduced, followed by onasemnogene apapovac, and finally in 2020 by risdiplam. So these children they not only preserve muscle function, but they even gain muscle function. And some of our children here with SMA1, who actually typically would die within the first 6 months of life, these children now start to stand and to walk. We still have the problems of early hip dysplasia, as well as the development of hip, knee, and foot contractures. And therefore, the concepts of orthopedic management are now slowly changing. This is a patient, so I have started to put those hips in, and I've done 3 patients the same way. All the 3 patients had multi-level surgery, releases of contractures, and whereas the rotational osteotomy plus Dega osteotomy. This is the last picture of this patient who was eventually 6 years old, and the hip is still located there. Of course, she's still quite weak, and the muscles are, the bones are quite osteopenic. We shall see how she further develops. However, these children are now able to walk, as I said. So I just wanted to show you one example, and I had to turn this around because on Windows it wouldn't work, only on my Mac. But this child had bilateral hip reconstructive surgery, including video Dega, had anterior guided growth to the distal femur, had hamstring release and bilateral tender Achilles release. And so thus far the results are encouraging. I just wanted to show you or give you the example and give you also perhaps the encouragement that with gene modulation therapy in those children, hip preservation, hip reconstructive surgery is worthwhile. And now we come to a few challenges in children with cerebral palsy. This is a patient with a repeat hip dislocation at the age of 15 years. The patient was, of course, in pain. The MRI, the CT scan, showed posterior dislocation. You also see that the acetabulum at the back is quite poorly developed, or basically probably eroded by the pressure of the femoral head. And I actually wanted to put the question to you, what you would do for such a child, for this child. I do understand that with the auditorium being so massive and so multiple, it's quite difficult to ask these questions, and this is why I will continue and tell you what I've done. Together, actually, this was the child which I've done with my colleague Abigail Kamble, and we've done a reconstructive surgery on both sides, video, and on the right side a Dega. The hip is now fully located, and we shall see what the final outcome will be. The next case I wanted to show is a patient with cerebral palsy and right hemiparesis. The patient was presented to me with a right hip sublux dislocation. The rehab physician actually apologized to me to present this child already with a hip dislocation, although the hip dislocation occurred quite rapidly. So I did a video Dega, and it looked all good for quite a few years, until the age of 13, when I then noted that the acetabulum was slowly wasting away again. And at the age of 16, the hip was basically subluxed and pain occurred. And for this child, I then opted to do a triple osteotomy at the age of 16 years. 3 years later, thankfully, the hip is still fully located and the patient is pain-free. But also growth has halted by then, and it is more likely that this will be a long-lasting result. Another patient with low tone cerebral palsy, GMS5, 10 years old, and the hips were dislocated for 5 years. And I would say 10 years ago, or maybe earlier, I would have said, well, it's probably too late to do anything about that hip or these hips. I did take an MRI to see what the cartilage layer of the acetabulum, not the acetabulum, sorry, the femoral head would look like, because typically if a hip is dislocated for a longer period of time, the cartilage erodes away. Thankfully, there was still cartilage on the femoral heads, and thus far, 5 months post-op, the hips are still stable, bilateral with video Dega, again, open reduction, of course, and there are no signs of AVN so far. That's the biggest fear. The biggest fear is AVN in those children, particularly if there was long-standing dislocation, and that's one of those children where I was probably not so lucky. I have no idea how long this 11-year-old had a right hip dislocation, but she was a good gym level 4, bad gym level 3. She could do at least transfer walking, and she was in pain, and therefore I opted to do hip reconstructive surgery. The acetabulum is basically non-existent, and therefore it was very tricky. And you can see that the coverage is still insufficient. She developed a massive AVN, which resulted in a defect healing. However, 4 years post-op, the patient was pain-free and was able to do some transfer walking. She probably will need at some stage a total hip replacement though. Okay, in summary, I would like to mention that from the point of etiology, hip displacement in cerebral palsy and low tone disorders is related to muscle function, and of course, muscle function also relates to gravity. Secondly, there's no clear evidence for abduction bracing in low tone muscle disorders. Thus, and therefore, it is probably not necessary or not indicated. Thirdly, I buy time, and many others do the same, buy time with adductor and psoas releases in children with cerebral palsy and hip displacement to minimize later bone remodeling. If I have, fourthly, unstable hips, I combine VDRO with pelvic and typically DEGA pelvic osteotomies. And of course, salvage procedures are the last resorts. Thank you very much for listening. I hand over back to Kiran.
Yeah, thank you, Matthias. Excellent presentation. You covered the topic completely. So, Dr. Benjamin, would you like to have some comments before we start the questions and discussion?
Yes, I would.
Yeah.
First of all, Matthias, you mentioned the swash brace.
Yes.
It was, there was an attempt to popularize it in India, but it was prohibitively expensive.
Yes, yes. Did you copy one?
So you know,
yeah.
It was just beyond the reach of most of my patients. And so I
yes. Yeah. I understand
that. I want to ask you is, if you find preoperatively by imaging or whatever, that there is some cartilage loss, would you still do a reconstruction? If at all you do it, what is the limit that you permit? How much cartilage erosion is acceptable for a reconstruction?
That's a very good question. So if I do an open reduction and find there's some cartilage loss, if it's like patchy, and I would say no more than about 25%, I still do hip reconstructive surgery. In one patient, I have actually taken cartilage layers from the back of the knee with a mosaic, or how do you call this technique?
Mosaicplasty.
Mosaicplasty, yeah. I did this in one patient that was successful, but it's almost, it takes a lot of time, and therefore it's for normal practice. And if you have several patients on the operating list, if you then during surgery find that there's not enough cartilage, it's a very difficult decision to make to open another joint to harvest cartilage. I've done this, as I said, I've done this once. I only needed to do this once. And but theoretically, yes, theoretically it's possible to patch the cartilage defects.
As opposed to the castle procedure that you advocate for as a salvage.
Yeah.
I tend to do an excision of the head and neck and a valgus osteum, a subtrochanteric valgus osteum. Do you have any objection for that as a?
So which osteotomy?
I abduct the distal fragment widely.
Yeah.
Almost like a pelvic support.
Yeah. So yeah, I have done.
Exercise the femoral head.
Yes. Yeah. Yeah. Actually, okay. So there's a few points. We did what we call the Schanz osteotomy. So an angulation of 45 degrees, proximal angulation of 45 degrees. in quite a few patients, and I thought we were very successful. In Australia, I know that it is not widely practiced, and one of my predecessors was actually unfortunately, strictly against it. However, he had one point to make, and that is, if you do the angulation, you create this very sharp angle or angulation of about almost 80 degrees. And that wears away over time, and the screws you put into that angle to stabilize the plate, you model the plate onto the bones in that angle, and the bones then wear away and expose the tip of the screws, and that can become painful. And therefore it can be a very useful operation, but it can also be a painful operation. And Leon Root in New York, he has several papers published about various salvage procedures, including McHale operation or McHale osteotomy, shunt osteotomy, Girdleston, and Castle procedure. And he found that the best long-term outcome was with the Castle procedure. And this is why I have lately, it's very rare that I have to do this procedure, but if I do it, I probably do the Castle procedure because it has, at least according to Leon Root, the best long-term outcome.
And finally, one more question. In spina bifida,
yeah,
there's a tendency now to say that if the hip is dislocated, you may ignore it, particularly if it's bilateral.
Yes. Look, there are Heidelberg, born and bred, basically. I started in the spina bifida unit, and every dislocated tip we put in, whether it was unilateral or bilateral. However, I have to listen also to what others say further down the track, and Luciana Diaz has quite well shown that patients, because they don't have pain, if they have bilateral hip dislocation and they have the function to walk, they will walk. They will waddle a bit, but they will walk. And there's no risk of redislocation in those patients. So therefore, there's no need to put both hips in. However, if it's a unilateral dislocation, yes, I'm strongly in favor of restoring that hip, and I will still do this.
Thank you. Thank you very much.
Thank you.
By the way, Menelaus, just as an add-on, Menelaus has written 2 books about spina bifida. In the first book, he was very liberal with putting the hips back in. In the second book, he actually devised this traffic lights situation, like red, don't operate, bilateral hip dislocation, a yellow, operate if it's a low lumbar, sacral, and both hips are dislocated, and green, unilateral hip dislocation if the patient is able to walk or has pain. Yes, definitely do reduce that hip.
Okay. Yeah, thank you. So, Matthias, I have a basic question that when we say there is a spastic muscles, we consider that it's adductor and the psoas, they are trying to pull the hip out. But what can be the reason in low spasticity or the low tone situations? Why hips dislocate?
Yeah, look, this is. I try to answer this with one slide. For me, the most important thing is muscle weakness, muscle imbalance. But the second most important thing is really the effect of gravity. So typically, normal children learn how to walk around the age of 1 year, and some palsy kids are typically a lot delayed, or they are unable to learn this. So the bones, I would say they don't know what to do. They have the muscle imbalance, they have the spasticity, they don't have the gravity which acts on the hip, which we see is so important for also to develop the rotation of the femur, the anteversion, which is Anteversion, we have 35 degrees of anteversion in a baby, and it slowly develops back. And that's actually a very interesting finding, because in the old books, we didn't have babies who had MRIs. Where do we actually get the knowledge from how the hip or how the femoral neck and shaft develops? We don't get this from MRIs of babies. No, we get this from dead babies. And that's what the old guys have done. So they have done body dissections, and have studied how the hips develop in regards to the neck shaft angle and in regards to anteversion. They actually found that in the first year, the femoral anteversion increased by 5 degrees, and as soon as gravity had an impact on the child, the anteversion reduced down to 10 degrees as an adult. So gravity is an absolute important factor for normal hip development, as well as concentric muscle action. And those children don't have concentric muscle action, and very, I would say, unilateral, only directed to one side. For instance, if they scissor, they have only the hip adduction, which actually pushes the hip out, because the femoral heads are directed laterally. They always push against the acetabular rim, wear the acetabular rim down, and then the hip dislocation happens to posterior typically, as well as proximal. Did I answer your question?
Yes, because we don't know actually what is the reason, but these are all the possibilities. I agree with that. Then there is another question, like we have 3 options for the management. One is a soft tissue procedure, that's adductor psoas release. The second is bony procedure in the form of varus osteotomy with or without acetabular procedure. And the third is salvage procedure. You very clearly said that when there is a 50% cartilage loss, you consider for the salvage procedure. But what about the indications for the first 2? That's the soft tissue procedure. When do you consider for that? And when do you consider for bony procedure?
Yeah, look, there's a couple of things again to mention. First of all is the age when hip dislocation starts. We have sometimes the combination of developmental dysplasia of the hip in very young children with cerebral palsy, actually even before the cerebral palsy occurs, but we find out about the hip problem only when the kid is 1 or 2 years old, and we have sometimes the combination. All right, then we have those children who are 2 or 3 years old, who have very spastic hips, and their hips are already lateral, often more than 30% or 40%. But I would say if they're somewhere between 30 and 40%, and there is a high level of spasticity, then I consider soft tissue releases. So adductor longus, gracilis, part, if not all of brevis, depending what the function will be of the child, and a complete psoas release. Interestingly, Mike Iona found he had actually released the psoas in patients able to walk, so children with 3s, for instance. He has released the psoas at the lesser trochanter and found now no difference between psoas at the rim and release at the lesser trochanter via gait analysis, which is an interesting finding to me. However, those children who are not able to walk, I still discern between. So I do children who are able to walk, I do a psoas at the rim only, leave the iliacus, and the others who are not able to walk, I do a complete release at the lesser trochanter, and then brace them, and then wait, and hopefully I can buy a couple of years. If displacement occurs again or progresses after my release, I had patients where I had to do a bony procedure, like a combination of video Dega, 6 months only after soft tissue procedures, because I saw that the hips were still progressing towards dislocation. Then I have to do something. So if it's progressive dislocation or progressive displacement, then I have to do something regardless of age. Otherwise, I try to wait until at least the patients are 6 years old, but ideally until the patients are 8 years, because 8 years will give me more likely a final result if I do a varising osteotomy.
Thank you. Yeah, Benjamin, please.
There is a question which is raised by Arul Murugan, which is very apt. He asks the role of a medial screw epiphysiodesis, and I, congratulate him for doing that, asking that question, because in some of your X-rays, apart from coxa valga, there's also an additional element of a caput valgum. So, is there a role of medial screw epiphysiodesis?
Yeah, look, I should have mentioned this. I started this recently, but I have no results as yet. So I didn't mention this because I don't have results.
All right.
But we started doing this, and actually Abe and I, we want to do a little bit more research about the screw. I know that that Kerr Graham has done this in Melbourne, and I know that there have been some favorable outcome, but it's not convincing as yet, I would say. So then more research and more observations need to happen to make this a procedure to be established in the in the armament or in the toolbox of orthopedic surgeons. Yes, I should have perhaps mentioned this. I have a few pictures, but I didn't show them. Yes.
Thank you.
Yeah. Then one important question, like you showed one case which was hemiplegic, and you did a unilateral surgery. Now the question is for a diplegic child who has a unilateral problem. In that case, most of the textbooks, they say that we have to carry out surgery, bilateral symmetrical surgery. What is your preference for that?
Yeah. So first of all, if it comes to soft tissue surgery, I mean, hemiplegics, I would consider only to do the affected side. Diplegics, they often have one side which is leading, which is worse than the other side, and one side is a lot softer. There are multiple papers out saying that surgery should always be symmetrical. So on both sides, however, the less affected side has less surgery, like less epiductal release, just to get symmetrical abduction, just as much to get symmetrical abduction. If it comes to bony surgery, I would say 20 years ago, I have started to do always both sides, because the more affected side, if I do a VDRO with a little bit of shortening, because I also do a Dega osteotomy, then I get a leg length discrepancy between 3 and 5 centimeters, and the patient has difficulties to sit in the wheelchair. In particular, in Australia, the wheelchair manufacturers are not able to make a difference in leg length. Even if the patient is not standing and doesn't do standing exercises, which is also beneficial to have a normal, an equal leg length. But it is favorable if both legs have the same length, and therefore I do a varus derotation osteotomy on both sides, and often a Dega osteotomy on one side to keep the length of the leg equal.
Okay, good. Then there is another question by is MS different, and what precautions we take while treating MS patient? Can you explain what do you mean by MS? You mean spinal muscular atrophy, or yeah, Maged, can you please elaborate on that? What question you are trying to ask? Multiple sclerosis. Fine. I think that we are focusing mainly in younger age groups, children. So we are not taking that question. The last question, which is I would like to understand the cultural difference. How many percentage of your patients where you explain surgery, they are ready to undergo this surgery for GMFCS 5 children?
How you mean how many?
Like say you suggest or you recommend surgery to 100 patients who are GMFCS 5.
Yep.
how many of them they really undergo surgery?
Oh, I would say the acceptance of surgery is very high in Australia, at least, also in Germany, by the way. Depending a little bit, we have progressive disorders, and in progressive disorders or in significant comorbidities where the risk of anesthesia is very, very high, then we of course reconsider surgery, in particular a hip reconstructive surgery. By the way, we have a medical team. We have introduced this in 2016, a medical team who looks at all the children, GIML 4 and 5, particularly the 5s, and their comorbidity, because they all have epilepsy, they have respiratory problems, they have other problems. And we need to regard this before the surgery can happen. And sometimes, yes, but it's actually relatively rare. Sometimes the parents decide not to undergo the surgery. However, in most children, even if they're severely handicapped, severely disabled, the prevention or treatment of pain still is priority. And stable hips means in future pain-free hips. And the life expectancy of GIML 5 children with modern medicine has greatly increased, has greatly improved. And it's also interesting to see how parents how parents connect to their very disabled children, and don't want to see them go, and do everything for those children, not only to survive, but also to have a relatively good life in a way that they're at least pain-free. And pain-free means hip preservation, hip treatment is a big step towards it. So I would say most of the patients or most of the parents agree and want this surgery.
Okay, there is one more question, but I will ask you that question later on, because we are already overshot the time. So
I see the Vera's question. I'm very happy to answer that Vera's question.
Please, if you are comfortable, then definitely, we can continue.
Look, in patients who are able to walk, I get the Vera's to about 120, 125 degrees. Those patients are not able to walk, 110, 115. That's my aim, at least. Sometimes it doesn't always 100% occur, but 110 degrees, I know that most of them will rebelgize a little bit. However, if you go below 110 degrees, you can get coxa vera. And then you have difficulties to abduct the legs because they get impingement proximally, And then I see this dystonia question. Dystonia, we have actually published a paper about dystonia, and we found that dystonia is very tricky to treat. However, it is worth treating. There can be unwanted effects. There can be, the results can be less favorable, or put it this way, not as good as you expect. But in many cases, we had actually good success, even in dystonic feet is, for me, the most difficult entity to treat. Dystonic feet are almost impossible to treat, I would say. But in most cases, the patients still benefit from surgery. So whatever you have to do, do it. If the patient is dystonic, there will still be a benefit. That's my message.
Okay, and then we missed one question in between, which is a very important question. Like, how do you decide to add on the acetabular procedure? Fine, we are definitely doing a varus osteotomy, but when you add the acetabular procedure?
Yeah, so first of all, steep acetabulum type 2 Saucil, according to Freeman Miller, which is blunted, because there's a high risk of, as I showed in this one patient, that didn't look so bad, but it was a steep acetabulum with a blunted Saucil, and that patient did very badly long term. So I decide definitely intraoperatively, if there's enough coverage, then I may say, well, we don't need to add something, but if intraoperatively on the II there's not enough coverage and the acetabulum is blunted and round, then I do a dig osteotomy, definitely.
Okay, and then there was a question about which procedure do you prefer and why? Triple over PAO? For a child who is 16 years or above?
Yeah. So look, I mean, I don't do PAOs, so I have to leave this to a colleague who is smarter and more skilled than I am. I do triple osteotomies occasionally that work typically quite well, I would say. But in some cases, I contact my colleague who does PAOs and hand the patient over for care. So, and of course, if the acetabulum is still concentric, then a PAO is the way to go. If it's not concentric, then you sometimes have to, if you want to improve coverage, you sometimes even have to add a valgizing osteotomy. And that I can do by myself by doing a triple osteotomy plus a valgizing osteotomy.
Okay, so thank you very much, Matthias, for sparing your knowledge and experience with us. And this lecture is going to be very useful to us. Thank you very much, Benjamin, for sharing again a very typical question. Benjamin is a very sharp person and very articulate person. So whenever he asks question, we have to be very careful because there is a wonderful point in his question. And Abhay, thank you very much for connecting our fellows, with the Matthias. And definitely we will have more session in future. So we are always eager to have you with us and learn from you. Thank you once again.
Thank you very much for having me.
Thank you very much.
Bye-bye. Bye. Thank you. Thank you.
Bye.
Yeah.
The recording has stopped.
Yeah, so now we can chit chat. Yeah. We are not on YouTube, so that's safe. Okay, so the session went really well. Your presentation was very to the point and very crisp and clear.